Welcome to the deep dive. Today, we are really digging into something fundamental, absolutely critical in med-surg nursing, assessing the respiratory system.
Yeah, this is core stuff. If you want to get patient care right, you have to understand this chapter.
Exactly. So we're taking the chapter summary, boiling it down to the essential physiology, the assessment signs you need to catch, and maybe most importantly, the big nursing safety priorities.
Right. Our goal is just to synthesize what's in this specific chapter. We'll go from the tiny details of lung anatomy right up to those high alert situations with diagnostics.
And it all comes back to those two big concepts, gas exchange and perfusion.
They're inseparable. If one's off, the whole system is in trouble. Understanding how they work together, that's the key.
Okay, let's unpack this. All right, first things first, let's get the terms straight. They get thrown around a bit, but they mean different things.
Uh-huh.
Gas exchange is the big picture, right? Getting oxygen to cells, getting CO2 out.
Yeah, the main goal. And under that umbrella, you have ventilation.
Which is just the mechanics, air in, air out.
Exactly. Simple movement, but then there's diffusion. That's the actual swap happening across those membranes in the lungs.
Down the concentration gradient, just basic physics, really.
Pretty much. And the third piece is perfusion. That's the blood flow, specifically arterial blood getting to the tissues.
Because you can breathe air in and out perfectly fine.
But if the blood isn't circulating to the cells, that oxygen never arrives. Ventilation without perfusion is, well, useless.
Makes sense. Now, the anatomy here really matters clinically. The upper airway, nose, pharynx.
Does that initial cleanup job? Filters, warms, humidifies.
Yeah.
And you got the epiglottis guarding the airway.
Preventing aspiration, hugely important.
And speaking of aspiration, the classic anatomy fact nurses need to know, the right main stem bronchus.
Ah, yes. Wider, shorter, straighter down than the left one.
Which means if someone aspirates something, or say an ET tube goes too far.
It's much more likely to end up on the right side. It's like the path of least resistance.
It really is. Then deeper down, you hit the alveoli. The source mentions their surface area is massive.
Like a tennis court, right, all folded up in your chest.
It's pretty incredible. And lining those alveoli are the type 2 pneumocytes. Super important cells.
Because they make surfactant.
Exactly. That fatty protein. Its job is reducing surface tension inside the alveoli.
So they don't collapse on themselves when you breathe out.
Precisely. Without enough surfactant, you get atelectasis alveolar collapse. That massive surface area just disappears.
And thinking structurally, what about the smallest airways, the bronchioles?
That's another key point. They have no cartilage rings like the bigger airways.
So they rely entirely on the lung tissue around them to stay open, that elastic recoil.
Yep, which makes them really vulnerable to collapse if there's inflammation or, loss of that elasticity like in emphysema.
Okay, this next part is fascinating, how the body actually manages oxygen delivery based on need. It's not just about picking up oxygen, it's about dropping it off effectively.
Right, and that's governed by the oxygen-hemoglobin dissociation curve. It sounds complex, but it's basically the body's smart delivery system.
It tells the hemoglobin molecule whether to hold on to oxygen tightly or let it go easily.
Exactly. Talk about shifts in the curve. A shift to the right means hemoglobin lets go of oxygen more easily. Think right release.
And that's good when tissues are stressed, like working hard, needing more O2.
Perfect. That's exactly when you want it. The conditions that cause a right shift are all signs of increased metabolism.
Like?
Increased temperature, increased CO2 levels, acidosis, meaning a lower pH, also something called increased DPG. These are all signals that tissues are busy and need fuel.
So the body automatically diverts more oxygen there. Smart.
Very smart. But the opposite, a shift to the left, that can be dangerous.
Because that means the hemoglobin holds on to the oxygen tighter. Like, it won't let go.
Exactly. Think left lock. The hemoglobin is saturated, your SpO2 might even look okay, but the oxygen isn't actually getting released to the tissues where it's needed.
What causes that?
Things like alkalosis, a higher pH, decreased body temperature, decreased DPG. That last one is relevant with, say, massive transfusions of older stored blood.
Okay, the clinical example in the source really brings this home. The patient having a heart attack and MI.
Right. The heart muscle is ischemic. It becomes acidic. That acidity naturally causes a right shift.
Helping release more oxygen right where the heart desperately needs it.
Yes. But if that same patient takes a whole bunch of bicarbonate antacids for indigestion.
Oh, they can make themselves alkalotic systemically.
Exactly. And that systemic alkalosis forces a left shift. Now the hemoglobin holds onto oxygen more tightly, actively worsening the oxygen starvation in that already damaged heart muscle.
Wow. So managing pH isn't just about numbers, it's directly impacting oxygen delivery at the tissue level.
Absolutely critical, especially in respiratory failure or shock states.
Let's shift gears to things that impact respiratory health over time. Aging, for instance. What changes happen?
Well, some decline is sort of inevitable. You get decreased alveolar surface area over time, the lungs lose some of that elastic recoil.
Making it harder to take deep breaths and exhale fully.
Right, and the cough reflex often becomes less effective too. Visually, you might see an increased AP diameter, the chest looking a bit rounder, sometimes due to kyphoscoliosis.
And what does this mean for nursing care in older adults?
It means their reserves are lower, they're at higher risk for hypoxia because they can't compensate as well. So you need to be really proactive with pulmonary hygiene.
Like encouraging turning, coughing, deep breathing, using that incentive spirometer.
Definitely, and a huge one.
Yeah.
Always assess for confusion. In an older adult, sudden confusion can absolutely be the first sign of low oxygen. It's subtle but deadly.
Okay. Beyond aging, we have to talk about smoking. Still the biggest preventable cause.
For sure. And assessing it means calculating pack years. Number of packs per day times the number of years smoked. It gives you a quantifiable measure of exposure.
We also need to ask about passive smoking, right? Secondhand, even third-hand smoke that lingers on surfaces and clothes.
Yes. And then there's vaping, electronic nicotine delivery systems, or NDS. The source flies the alveoli outbreak from 2019.
E-cigarette or vaping-associated lung injury, that caused severe acute respiratory problems.
It did. And beyond that specific syndrome, there's the risk of inhaling toxic metals like cadmium, nickel, chromium from the heating elements. We also need to tackle the myth that hookah is somehow safer. It's not.
Good points. What about environmental or occupational exposures?
This is where the I Prepare model comes in handy. It's a structured way to ask about particulate matter exposure, PME.
Let's break that down. I prepare.
It stands for Investigate Potential Exposures, Present Work, Residence, Environmental Concerns, Past Work, Activities, Resources, and Referrals, and Educate.
So it helps you remember to ask about their job, history, hobbies, where they live.
Exactly. Think about bakers and flour dust, welders and metal fumes, farmers and agricultural dusts. These things are linked to chronic lung disease, and this model helps you uncover those risks systematically.
All right, let's move into what we actually see and hear when assessing. Subjective stuff first, what the patient tells you, dyspnea or shortness of breath.
And it's not enough just to note, if they're breathless, you need to know how bad it is. The source uses a Class I to V scale.
How much does it interfere with their daily life? Like class I is maybe just with really heavy exertion, whereas class V...
Class V means they're pretty much housebound, dependent on help for almost everything because of breathlessness. It quantifies the functional impact.
Got it. And specific types, like orthopnea.
That's shortness of breath when lying flat. They'll often tell you how many pillows they need to sleep.
And paroxysmal nocturnal dyspnea, PND.
That's the scary one where they wake up suddenly from sleep, gasping for air, often related to fluid shifts like in heart failure.
Okay, what about sputum? What are the red flags there?
3 key ones jump out. First, pink, frothy sputum. Classic sign of pulmonary edema. Think fluid backing up from the heart.
Second?
Rust-colored sputum strongly suggests bacterial pneumonia, like pneumococcal pneumonia.
And third?
Foul-smelling sputum. That usually points towards a lung abscess or maybe a nasty anaerobic infection.
Moving to objective findings, what we see and feel. Chest shape.
You look for that barrel chest. Normally, the chest is wider side to side than front to back. In conditions like emphysema with chronic air trapping, that front to back dimension increases, making the ratio closer to 1:1.
And palpation, feeling the chest wall.
Yeah,
Crepitus.
yeah, that's air trapped under the skin. Subcutaneous emphysema, it feels like Rice Krispies crackling under your fingers.
Where might you find that?
Often around chest tube sites, maybe after neck or chest surgery, or sometimes with pneumothorax. If you feel it, especially if it seems to be spreading, you need to mark it, document it, and report it. It's a sign air is escaping where it shouldn't be.
Okay, what about fremitus? Feeling for vibrations when the patient talks.
Fremitus tells you about the density underneath. If the lung tissue is denser, like with pneumonia or solid mass, the vibration travels better, so semitus is increased.
And if there's air or fluid in the pleural space between the lung and the chest wall.
That dampens the vibration. So with a pneumothorax, air, or a pleural effusion fluid, fremitus will be decreased or even absent over that area.
All right, let's hit auscultation. The 4 main adventitious or extra breath sounds. Can you quickly distinguish them?
Sure. Let's start fine. Fine crackles, high-pitched, popping, discontinuous. Think of hair rolling between your fingers near your ear. It's air popping open small, deflated airways. Common in atelectasis, early heart failure.
Okay. Wheeze.
Wheeze. High-pitched, musical, usually continuous, more common on exhalation but can be inhalation too. That's air being forced through narrowed airways. Think asthma, bronchospasm.
Bronchi.
Ronti.
Philip.
Lower-pitched, coarser, snoring or rumbling sound, also continuous. This suggests secretions or obstruction in the larger airways. Often clears or changes with coughing.
And the last one, pleural friction rub.
This one's distinct. Loud, grating, scratching sound, like leather rubbing together. It's caused by inflamed pleural layers rubbing against each other during breathing, heard on both inhalation and exhalation.
Okay, wrapping up with diagnostics and key interventions. Non-invasive tools first. Pulse oximetry, SpO2. Everyone uses it, but what's a key limitation?
A really important one. Results can be falsely lower in people with darker skin tones. It has to do with light absorption through the nail bed pigment.
So you can't rely solely on the number, especially if it seems off from the clinical picture. What's the critical value we need to react to?
Generally, for someone without chronic lung disease and SpO2 consistently below 91% is an emergency, needs immediate assessment and intervention.
And what about capnometry or capnography, measuring end-tidal CO2 PETCO2?
This is often a more sensitive indicator of gas exchange problems than pulse ox. Normal PETCO2 is around 20 to 40 millimeter Hg.
Why I'm more sensitive?
Because changes in ventilation, affecting CO2 removal, happen before significant drops in oxygen saturation usually occur. So rising PETCO2 can alert you to hypoventilation earlier than a falling CO2 might.
Good point. Now, invasive procedures. Safety is huge here. Bronchoscopy. Key prep.
NPO for 4 to 8 hours beforehand. Absolutely critical to prevent aspiration when they numb the throat.
And the big safety alert with the numbing spray, often benzocaine.
Risk of methemoglobinemia. This is rare but serious. The benzocaine changes the iron in hemoglobin so it can't bind oxygen effectively.
Leading to profound hypoxia even with supplemental O2.
Exactly. And the telltale signs, the critical rescue cues you need to spot: cyanosis that doesn't improve with oxygen, and if blood is drawn, it looks chocolate brown.
If you see that.
Call the rapid response team immediately. It's a medical emergency requiring specific treatment.
Okay, another procedure, thoracentesis. Draining fluid or air from the pleural space. What's the patient's role for safety?
They must remain absolutely still. No moving, no coughing, no deep breaths during the needle insertion. Any sudden movement could puncture the lung.
And there's a limit on how much fluid is removed at once.
Yes, generally limited to about 1,000 millil. Removing too much fluid too quickly can cause re-expansion pulmonary edema. After the procedure, you monitor closely for complications.
Like a pneumothorax, what are the signs?
Absent breath sounds on the affected side, maybe increased respiratory distress, pain that worsens with breathing, potentially a deviated trachea if it's a tension pneumothorax.
Okay, let's touch on health promotion smoking cessation. The chapter mentions the 5 As model.
Right, a simple framework. Ask about tobacco use, advise them to quit, assess their willingness to try, assist them with resources or a plan, and arrange follow-up.
And finally, some drug safety alerts related to quitting.
2 big ones. First, with nicotine replacement therapy, NRT, patches, gum, etc., patients absolutely cannot smoke while using it. It dramatically increases the nicotine levels in their body, significantly raising the risk of heart attack or stroke. And second, for meds like bupropion or varenicline.
There's a black box warning.
Yes. These drugs can sometimes unmask or worsen serious mental health issues, things like manic behavior, hostility, even hallucinations. Any major behavioral change needs to be reported right away.
Wow. Okay, so we've covered a lot. From the tiny type 2 pneumocytes making surfactant through that whole oxygen hemoglobin dance, right up to recognizing life-threatening complications like methemoglobinemia or pneumothorax.
And hopefully you see how all those assessment findings, the crackles, the wheezes, the fremitus changes, the sputum color, they all tie back directly to how well those core processes, gas exchange and perfusion, are actually working.
It all connects.
A huge thank you from the Last Minute Lecture team for joining us for this deep dive into respiratory assessment. We really hope breaking down this chapter helps you build that solid foundation.
And before we sign off, here's something to think about. You're in the middle of a code or maybe managing a patient with severe trauma, something completely unrelated to their smoking history.
Yeah.
In that high-stress, critical moment, how do you realistically, ethically apply those 5 A's for smoking cessation? Where does patient education fit when immediate survival is the priority?
Just something to consider as you navigate the complexities of real-world nursing. We'll get to on the next deep dive.